years, after 1 year, after 6 months, and we just don't know. And so, and no pharma company is actually going to run this because most of the time they want their drug to continue forever, given the let's just say the amount of revenue that they can generate from these drugs. But as you can imagine, there's toxicities for continuing on these drugs. There's a financial cost. There is an operational cost. There's all these things that make for a very interesting question. And how this started, and we do know now that these PD-1 drugs are a little bit different than just say chemotherapy, as you know, where there's a memory that can happen with these T cells where these responses can occur even after you stop immunotherapy. And we've actually seen this preclinically and in everyone's clinics that you have patients who stop a PD-1 drug for whatever reason, some sort of toxicity or for whatever, and they continue to have a response even years later. So we started with just a basic question and surveyed our oncologists. And in the network, we have about 130 medical oncologists. I mentioned about 38 sites of service. And we asked them, would you be willing to participate in a clinical trial that determines the feasibility of stopping a PD-1 inhibitor after 1 year? And overwhelmingly, we got around 100 responses, and most said yes, they would like to do and participate in a trial like this. Now, we weren't going to do liquid tumors, but we were just going to focus on advanced metastatic solid tumors. And we also asked, what is the minimum response you're comfortable with discussing this trial with the patient? And then there was a lot of different various answers with, as long as it was a stable disease, a 30% regression, less than 10% regression. But it was a little all over the map. But at the very minimum, the docs were willing to talk to the patient to have a discussion about whether or not they would be able to participate in a trial like this. So this is Hillman Cancer Center 19-135. This was to evaluate the length of treatment of a PD-1 inhibitor with patients in advanced solid tumors. To address the optimal length of a PD-1 drug. And it was the primary objective was was progression-free survivalship. The secondary was overall survivorship. Another secondary was to see if you stop, then would you respond again if you went back on the same PD-1 inhibitor. So we designed it so at 9 months we would identify these patients. And then we would offer them, we would talk to them at the 9-month mark. And then at 6 weeks prior to the 1 year that they've been on the drug, they had a scan to see if everything was at least stable. Then they can be enrolled or randomized to either stopping or continuing. So it was a 1-to-1 randomization. And it was, you had to be on a PD-1 inhibitor for at least 1 year continuously, with a little bit of leeway if you missed 1 or 2 treatments throughout the year based on various things. It could be investigator choice to allow it. But basically, it was a pretty simple trial. It was basically you have advanced metastatic solid tumor. You could stop the drug after 1 year or continue it. And then if you continued it, you would be watched just like standard of care, scans every 3 months. And if you stop treatment, you were scanned every 3 months as well. And if you progressed, you could go back on a PD-1 inhibitor. Our goal was 578 patients. We were supposed to have other correlatives and blood draws, and and maybe think about utilizing tumor DNA or whatever to kind of watch these patients. But unfortunately, we couldn't get enough funding to provide that. So we just made it very simple: was stop the patient or continue after 1 year. And we also created, this was actually new for UPMC Hillman Cancer Center. We created an in-house PD-1 stop patient application where we were able to use billing data to help have a trigger for alerting our clinical research coordinators whenever a patient was getting to the 9-month period of being on a PD-1 inhibitor. So an alert would go to the clinical research coordinator to say, hey, look, there's a patient who's approaching the 9-month period who's had it continuously, please talk to a physician about whether or not they would want to approach a patient regarding going on this trial. And then what we then tasked the CRCs to do is that if the patient or physician said no, they declined, we were tracking the reasons why they were not going on the trial, so we could actually learn what was happening and kind of in real time, kind of address what the issues were for not putting a patient on a trial, and then see if we could find strategies to try to help accruals in this regard. So this was actually something that was never done before at UPMC, and it was a very low-tech way to do it, but it was actually very helpful in identifying patients to make sure that doctors were reminded about this particular trial. So here's our data. Our goal was 578 patients, and 6 years into it, unfortunately, we're only at 147 patients. And as you can see here on the left side of the screen, the application we had screened just under 6,000 patients to see if they were eligible. And of those 6,000, about 1,000 fit the criteria for eligible. And they were able to be approached by our CRCs, our physicians, and we were able to consent 193, and we accrued 147. As you can see, there was a lot of different reasons of that 6,000 why they weren't eligible, be it they weren't eligible because they were already on a clinical trial, they progressed, at the 9-month mark, the patients declined, the physician declined. And as you see on the right side, the purple bar graphs are the pool of patients that that were eligible for going on this trial. And it actually increased over time since 2020. We started to include a lot of different patients as far as their disease sites, like it was all comers. At first, we excluded certain more aggressive cancers like small cell, but we started to include them. We actually expanded our reach in other sites within UPMC, not just in Pittsburgh. So, but unfortunately, as you see here, the number of patients that were eligible increased dramatically since 2020 and 25, but the number of patients who accepted went down. So really the biggest push was actually the first 2 years, where we got about 100 patients. And there was a lot of hope that we would get to the 578, but then over time, 22, 23, 24, 25, it just started to go down dramatically. And this has to do with a lot of things between COVID, other trials, physicians kind of forgetting about it. And so a lot of reasons, which we'll talk in a little bit. So 147 patients we were able to actually accrue, which actually is pretty good considering it was this is just one university, but we're hoping for more. And as you can imagine, with not only getting 147 patients, it's going to be a very underpowered trial. So what did we get so far? And we hit a bunch of different safety points to show that there was a lot of signal that this was a very safe trial. And preliminarily, what we see in the red is the people in the stop, people in the line of black. It was actually statistically insignificant whether or not they, as far as overall survivorship, if they stayed on or stopped. And same thing with the progression-free survival between the stop and the continue arm. Actually, they were exactly the same. So it's at least in the first part of the initial analysis, there was really no difference between continuing or stopping after that 1 year. What we did then was broke it down a little bit more. We said, well, what if we look at certain cancer types? And we saw here was the majority of patients that were accrued on this trial were non-small cell lung cancer, about 47. Then we looked at melanoma and head and neck. And what we did was we broke down those 3 specific sites, melanoma, head and neck, and non-small cell lung cancer. And we started to look at some specific questions. So just like the overall picture, it didn't matter if you were stopping or continuing, it made no difference whatsoever. either way. And then we started to ask ourselves, because this was a question by our physicians when we started to ask them, what's the barriers for putting people on this trial? And a lot of the physicians were saying, well, I, I'm I don't want to put people on the trial because they're having a response. And since they're having a great response, I feel uncomfortable putting patients on this trial. Well, what we did was we took melanoma, lung cancer, and head and neck cancer, and we said, okay, well, what if you had a 30% reduction by RECIST criteria? Was there a difference um, in their overall survival or the progression-free survival? And actually, if they had a great response, over 30% reduction, it didn't make a difference if you're stopping or continuing. And then we said, well, what if there's like a 10% reduction? And it's the same thing. There was no difference between continuing or stopping. Now, I know the numbers are smaller, but at least it's showing you a trend or signal that it really didn't matter if it was a 10% or 30% reduction. It didn't matter if you continued or stopped. Then the other comment we got from our physicians was, well, you know what? We don't want to put people on this trial because there are multiple lesions all throughout the patient because it was quote unquote very aggressive. So we said, all right, so let's look if there are multiple lesions. In this case, we looked at more than 10 in the original scan, 10 different sites in the body. And once again, overall survival, progression-free survival made no difference if you continued or stopped. And then the other question was, our doc said, well, my patients are older, they're frail, we don't want to stop it. But when you look at their age of 65, greater than 65, it didn't make a difference at all. So as you can see from here, once again, underpowered because it's a smaller number than we anticipated, showing you preliminarily that it really doesn't make a difference for how the response, the aggressiveness, or their age, whether or not you stopped or continued. And we do know when you continue, particularly this particular drug, there can be long-term toxicities with pneumonitis, colitis, arthritis, and actually the financial cost for patients coming in every 3-4 weeks or every 2 weeks for these IO drugs, what it can do for them. So this was actually very compelling data for what we could do that could be impactful for our docs. Now, the other thing is what happens for, if the questions for complete responders, it was the same thing, not much change or difference between overall between stopping and continuing. And also if patients were on their second line of therapy versus first line, it didn't matter either. So I mentioned that this is great data. We presented this to our docs. We said, hey, look, if we can get more people on this trial, we can actually have it powered correctly, and it could be very impactful for across all disease sites for patients. But as you can imagine, in Ireland, as in Pittsburgh, there are a lot of accrual challenges for clinical trials, and this is actually a kind of like a secondary thing that we were watching. And that is, what are the barriers to getting people on this trial? Obviously, we presented this data, which is very compelling, and and it was the same thing. It was the CRCs, the clinical research coordinators weren't screening, and still, when we said about the tumor burden, aggressiveness of stopping the drug, even though we'd show the data, a lot of the doctors still weren't convinced. This probably happens in Ireland, but also in Pittsburgh. We only have about 15 minutes to talk to patients in our clinic. So we have a lot of our docs said there's just not enough time to discuss this trial. The resources to help get these patients to trial weren't adequate. Some docs said they didn't know about the trial. They were worried about, some people worried about insurance coverage. So a lot of different reasons for why they didn't want to go on a clinical trials when we asked the medical oncologists. And then we looked at our application tool, which was really interesting too, was what about all the declinations? What did we glean from why patients or physicians didn't want to do this? And it was actually, you look at the different years, a lot of it had to do with just the doc was just uncomfortable with the amount of tumor they had in the patient, or the aggressiveness or the pervasiveness of the disease, which makes sense. If I was a patient and I had extensive stage small cell lung cancer and I have disease everywhere, and this after a year, you have stability. It's hard to tell them to stop a drug. Same thing with the patient. You've asked them, why would you want to go on this trial? And a lot of them said they were just really concerned about changing anything that was working, and they're concerned specifically of stopping therapy and cancer spreading. So these were very big barriers to overcome, even though there was data that would show that it didn't matter the tumor burden or the aggressiveness of the disease. It was just very difficult to overcome these biases. We also found that there was this miseligibility window, even though we had this application to help trigger our clinical research coordinators say, hey, look, approach the docs. Once again, people get busy, people kind of forget, there's a lot of different things happening. And so there was this big bucket of patients, 162 in the red, that just weren't approached. And so in 2023, up until now, we have this huge push to try to get this, approach this and shrink this eligibility window so we could approach more patients. And so we did a lot of different things by communicating the trial's importance to the three major groups in Pittsburgh, OHA, HOA, and UPP, to re-energize and educate the CRCs. We marketed the communications to patients with more materials, with various marketing tools like a patient story. We did that was that this patient had been off PD-1 drug for over 4 years and still doing well. We once again tried to improve our analytics, once again to show the data, but also to get the CRCs to use the tool we had. So we did a lot of different things to try to reinvigorate this trial, because at the 6-year mark, we were kind of still sputtering along. But unfortunately, it didn't quite work. So actually, just last week, we actually decided to close the trial so we can start to take the data and do a more robust analytic analysis. And this was because, as I showed you, the accruals were just decreasing dramatically. And also, we're going to have 2 new clinical trials. We're going to have overlapping patient populations with more flexible eligibility criteria. That was going to cause some tension between the two with the multiple trials. And we actually approached Cork as well to see if there was an international help to try to get patients on this trial. And we actually went pretty far with Jack and trying to get through this. But as we found, there was funding that was needed to open this trial, which caused some issues. So we were unable to open it here with you guys to partner. And then also the funding for this trial was ending in 2026. And then our identification tool was ending as well. So not surprising when it comes to clinical trial accruals for everyone. It's hard to get people on clinical trials, but there's actually this trial, there's a lot of lessons learned, but unfortunately we didn't get to the number we wanted. But I'm still very hopeful that the data will be presented at ASCO next year, and hopefully you'll get some play. Although of course there's going to be some inbuilt challenges because of the lack of patients, but still very interesting data that I think that we are able to do from this trial. And some of the lessons learned is we can actually apply to other trials. And this is actually a trial that's going to be opening in a couple months here at UPMC Hillman Cancer Center across our network. And that is looking at sub-Q versus IV immunotherapy. And this is just showing you the various minutes and time of Keytruda, Ipi, and Nivo alone. And a lot of time spent for a patient is around 2 hours or 3 hours. Sitting in a chair, resulting in patient missing out of work, leisure, being with their families. And it's interesting there, and the FDA just approved here in America of sub-Q Opdivo, which was shown to be non-inferior to IV Opdivo, as you can see here. And the timing of using sub-Q is so much shorter. It's only about, it's less than 30 minutes, whereas the IV Opdivo can be as much as an hour. So it's, and if you ask patients in some trials, they preferred the sub-Q method. So what do we see here in Pittsburgh? Actually, of the most recent starts outside of a clinical trial of Opdivo, only 10 were sub-Q, over 600 were IV. So that should tell you that when docs get used to their bias of which drug and delivery method they want to use, typically it's one they're used to, so IV. But this is actually an opportunity to look at a trial to see if we can actually change the doctor's preference, and also have a very simpler trial to actually get just accrual and get people to partake in more clinical trial accrual. And basically it is people start Opdivo, and they can go on either sub-Q or IV, randomized 1-to-1, and then they switch to IV, then sub-Q. And then after a total of 6 cycles, a patient can then select which one they want to go on, and they continue. And actually, there's another arm that was created for those already on Opdivo, not just a new start. If they've been on it for a year, 2 years, 3 months, they can be randomized as well to the opposite that they're on. So if they're already on IV, they can randomize to sub-Q for 3 cycles. Then the patient can select which one they want. So I know it's not the most sexy trial, but once again, it's something that can help accruals, number one, to just participate in more academic trials. Number two, it's actually something that's good for patients and to change behavior for our docs. Obviously, I think sub-Q is probably the way to go for these patients. But I think it's going to be interesting as a patient as a patient preference. We've learned from our trial for the PD-1 stop drug to have patient control of which one they would choose is a huge difference. Actually, in the PD-1 stop trial that we had, a lot of patients didn't want to go on our trial because they wanted to either continue or stop. But they wanted to be able to choose it. And the other thing is, we see that when you talk about just the cost for a patient, be it financial, be it for time, you can't really put a number on that. I think that just very, very broadly, when you talk about just getting your docs to be involved in a trial that's easy for one to remember, one that doesn't require delays in getting patients on, you're just looking for trials like that just to try to get them kind of engaged into the scientific mission of clinical trials. So our next steps is we're engaging just going to our IRBs, our PRC committees, and we're looking to start this trial in the next month or two. So that's going to be one trial. There's another one about early versus late, which is coming in a few more months. But this one is one that we're hopeful will be ready to go in another month, and hopefully with your team at Cork to see if that's something you guys would be interested in participating as well, something easy for your docs to get patients on trial. And I see I'm close to time, but thank you for listening to me. These are my kids. My wife is 100% Irish, and we'll be going to Ireland actually next year, although my son, who likes to play football, he's hoping we wait till 2028 because he said that you guys are hosting the Euros, and he's would like to come and watch his favorite team, Spain, play there. So with that, I'll stop and see if you guys have any questions.
That's great, Vincent. Thank you very much for your talk. Thank you. Can I just ask very briefly, just before people think of their questions, the whole area of subcut immunotherapy? I mean, I see that atezolizumab has been approved a while ago. Nivolumab is now approved. Pembrolizumab is being approved. Can you envisage a day where all these drugs are given in the community in primary care before the patient comes to the cancer center, or do you think that's realistic?
I actually don't think so, because these drugs, even though they're very, it's easy to give, right? It's easy to give a sub-Q shot, but the expertise that they get, not just in our clinic, but your oncologists in Ireland, is all the extras with it. It's the description with the patients. It's making sure that the protocols and the drugs are given adequately and safely. I don't think that anything can substitute being in a cancer center with our staff to give these drugs. And these drugs are still dangerous, and we have to be careful with them. And actually, I don't know how it is in Ireland, but there's a big push by insurance companies to give more drugs at home rather than in our infusion centers. And a lot of it has to do with cost, which we are really adamantly against, just for a medical legal standpoint, if something should happen to patients at their house. But also, when patients are here in our office is when we can watch them. It's really a safety issue. And with all the other things that they get in our office specifically with the dietary consultations, our pharmacists, and everything else.
Yeah, I'm inclined to agree with you. Great, thank you. Anyone else have any questions for Vincent? I think we had the same issues here with the melanoma study about opening it, and the discontinuation study. It's a hard sell sometimes to patients, isn't it, to stop the drug versus continuing it given the response?
It's I think we're a bit naive. When we created this trial, we thought it was going to be the easiest thing to sell because we thought patients would be like, wow, this is great. We can stop our drug and don't have to come in. But you're right, Derek. I mean, it is tough for patients who know they have metastatic advanced cancer to say, oh, you know what, this is working. I'll stop it. It's a huge barrier. And I think that's one of the things that is tough for both sides, physicians and patients, to do. And I think we were a bit surprised by that.
Great, yeah, thank you. My colleague Professor Roisin Connolly has a patient. Hi, Roisin.
Oh, hi. So I saw your text.
Hi. Yeah. Hi, Vince. Thanks so much for speaking to us today. That was really interesting. I actually have two questions. One is around the trial and the clinical trial alert system. So can you tell us a little bit more about, I suppose, who drove that idea? What were the logistics involved with getting that up and running? Because that's obviously the most ideal situation to have automated identification of patients matching with clinical trials. Do you use that system for all of your clinical trials? Is there institutional sort of buy-in and support behind that? How does it work for you all there?
Yeah, great question. It was very innovative to create this. The reason why we were able to do this is that we have a lot of problems with identification of patients for adequate clinical trials for across the board. And that's one of the biggest barriers for our docs, is that they can't remember all the trials that are available for all the patients. And when the patients come, when are they supposed to be approached? And where's the truth of who's going to try to access all this information? And usually billing data here in America is usually the truth of where everything is. And what made this trial and this application more unique is because we had a lead time of 9 months to identify these patients. So we were able to use the billing data and create a tool that was able to look at Opdivo billing and Keytruda and all those ones, so it could come into the system, and then we would be able to kind of say, oh, this particular patient has 8 months of billing of Opdivo, and then it came into this program. And so it was actually designed by one of our project managers working with UPMC's billing team to create it. And unfortunately, it's not one that we can use all throughout because it's based on billing data, and billing data is late as well. So it takes about a month or two for it to come in. That's why there's a big lead time. So when it was built, it was really just built specifically for this particular trial and not for anything else, given how we're using billing data as the source of truth.
That's great. We have a new national cancer information system which is rolling out and will be used for electronic prescribing because we're a little behind other countries in terms of national electronic health records. So, whether we can use some of these tools to do similar things and our existing sort of clinical trial or cancer databases is what we're looking at right now. So it's really interesting to hear about this. And just the other question that I had was, around the Hillman network approach, the one Hillman, because we have a number of hospitals in our region as well, all providing cancer care, and we are hoping, with support from our regional health service leadership, again, it's a little bit different. We're working in the public sector, so it's not private sector. But the idea of, a central hub and again, the same care, the same quality of care across all of these locations. What are the sort of, I suppose, challenges around that approach that you have seen, and how long has that system been in place versus the opportunities that it provides?
No, great question. I mean, it actually has been around. This particular system has been around for about 20, 25 years. Before this all started, all the oncologists were loosely private practice based. And then it was, the real driver was the chairman of our group now, Stan Marks. He's actually the founder and created this one big group, one Hillman. And I think that's where the big thing that you need to try to make this work is you need physician leadership to try to make sure that all the physicians have a voice. Because before all of this, that's the biggest problem, was the having everybody doing the same thing, because it sounds like cookbook medicine. It sounds kind of like, oh, I don't want anyone to tell me what to do. I've done this for X amount of years. And that was the hardest part. But once you have buy-in from the physicians who are actually led by a physician and create an environment of trust where everyone has a voice, that solves a lot of problems in the beginning. But the other issues that occur is, how do you create initiatives like a PD-1 stop trial and do that across multiple sites, multiple areas, multiple different patients? And I think that's a very big challenge that needs a lot of operational heft. And that is probably the biggest challenge. Is UPMC likes to do things on very leanly, as I'm sure they do at Cork. And operationally, we don't always get the support that we would love to have, especially given how big we are. But that's a huge challenge when it comes to trying to do what you want to do and having the finances to do it.
Thanks so much.
Great. Thank you very much. Any other questions, anybody? That was very informative, Vincent. Thank you.
I appreciate you guys having me, and I look forward to, if you're ever in Pittsburgh, or I'm happy to have more discussions about Hillman and UPMC and other ways we can partner, because we do value Cork, and even though we couldn't get the PD-1 stop trial to work there, we're always looking for other ways, other trials, because I think that whenever you look at our friends over there in Ireland, we really do consider you guys part of the network as well.
That's great. Thank you. Thank you for the collaboration. I think we're finished now a little bit earlier. Our second speaker couldn't make it, but that's the end for today. Thank you, everyone.